We now move on to the symposium. May I cordially invite Professor Nilanka Pereira and Dr. Kitsiri Nuanhella to chair the session.
Welcome to the session on infectious diseases, defeating infections responsibly. And first lecture will be by Dr. Mahen Kotalawala, and he will be discussing on role of microbiological investigations in targeted therapy. He has MD microbiology, MPH, and he's a consultant clinical microbiologist at National Hospital, Sri Lanka. Over to you, Mahen.
Right, good day. Thank you very much and giving me this opportunity. My topic is role of microbiological investigations in targeted therapy. So my topic has two segments. One is to discuss the role of microbiological investigation. So that is something that I do, and how I can be helpful for you to decide on targeted therapy. So this is how I'm going to present my talk under these lines. First, I would like to give you a generic framework of antimicrobial administration. I tried to incorporate all indications for antibiotic prescription. So you know, antibiotics are different and it acts on bacteria and living organisms, not on human cells. So during last few weeks, I tried to gather all possible indications for antibiotics, and I have condensed it into one slide. So this is what I have come up with, the indications for antibiotics. So if you prescribe antibiotics to any other indication other than these, you have to think twice. So what is the type of treatments? One is empiric therapy, second one targeted therapy, the prophylaxis, preemptive therapy, combination therapy, salvage therapy, suppressive therapy, and compassionate therapy. So I have given all the small description in small letters, and 95% of the time, your prescriptions, if it falls within any of these topics, so you can say that you are doing a rational job. In this presentation, I would like to give you on two aspects of this. One is empiric therapy. So generally, the empiric therapy is something that you guess on empiric basis. It's an educated guess based on your knowledge. So it is something that you do in the immediate phase of infection to cover the initial period. So it is done before identification of the specific pathogen causing the infection. So basically, earlier we used to call it blind therapy. So that is, you give something based on your knowledge on infectious syndrome and the coverage of your antibiotics that you are going to use. So what are the disadvantages of empiric therapy? We know them. Advantages. So what are the disadvantages? This is very important to note, because when you are giving empiric therapy, so you are promoting these things. Number one, promote antibiotic resistance. Second one, it risks ineffective treatment, because when you are applying empiric therapy, so you are giving a learned guess, and it depends on your experience and coverage. So therefore, there is a chance of ineffective treatment, and it can lead to adverse side effects, increased healthcare cost, and it will obscure definitive diagnosis. So this is the big minus in empiric therapy, because you are giving on your knowledge to treat the infectious syndrome. So that will obscure the etiological agent, and you might overtreat the patient, which is not good for antibiotic stewardship efforts. So what is targeted therapy? Targeted therapy is a type of precise treatment. So how are you going to do the targeted therapy? You identify the pathogen and you treat focusing on that particular pathogen causing the infectious syndrome. So this is the best form of treatment. So if you ask me, what is the best form of treatment? What is the gold standard treatment? I would tell you it is the pathogen-directed therapy, which is the targeted therapy. So basically, the targeted therapy is focused on particular organism. So therefore, you can use narrowest possible spectrum of antibiotics to treat the patient. And it will reduce the resistant development. So what is the benefit of targeted therapy? Number one, it maximizes the efficacy, uses the right drug for a specific drug. That means you are covering only the organism which causing the illness. And it minimizes the collateral damage. So now when it comes to antimicrobial resistance, when you treat with a broad spectrum antibiotic, what will happen, not only the targeting organism, but the other organisms in the vicinity will develop antibiotic pressure and they will develop antimicrobial resistance, which will be a bigger problem subsequently. And when you give targeted therapy, it is good for prevention of antimicrobial resistance. So now when you have empiric therapy and targeted therapy, so there has to be a way to switch from empiric to targeted therapy. So how are we going to achieve that? So basically, what type of treatment you need depends on the urgency of the presentation. So we know in sepsis, which is a medical emergency, where every hour counts, so this urgency creates a treatment gap from switching to empiric to targeted therapy. So when a patient comes with sepsis, you try to give empiric therapy and to stabilize the patient. So once the patient is stabilized, so you can achieve targeted therapy. So the basic aim of this is to rapidly move away from empiric therapy to targeted therapy. So that is why we want to reduce the broadness of initial coverage with targeted therapy. And at the same time, we want to keep the patient and minimize the duration of antibiotic exposure and keep the patient without antibiotics as soon as possible. For patients with sepsis, antibiotic treatment should begin as early as possible and must not be delayed pending the collection of specimens. So this is the summary of what I am going to tell today. Is that if you delay treatment in sepsis, it will lead to poor outcome. And if you rapidly institute the antimicrobial therapy, initially empiric, later targeted with the infusion of microbiological inputs, so that will end up in good mind. In patients who do not present with sepsis, so you have all the time in the world to do the microbiological test and institute appropriate treatment. So how are we going to switch from empiric to targeted therapy? This is how, within day 1 or day 2, you just think whether the patient needs empiric therapy, sepsis or septic shock, you give empiric therapy. And if the patient is not having sepsis or septic shock, so you can wait for lab results and consider converting to targeted therapy with the input from laboratory. All modern antibiotic stewardship programs balances the rapid empiric treatment in urgent setting with a timely transition to the targeted therapy. Switching from empiric therapy to targeted therapy is guided by crucial data from microbiology laboratories. So that is how I come into the equation. So what are the tests available in microbiology laboratory to help you to arrive at targeted treatment? So basically the modern microbiology laboratory uses combination of conventional and rapid test as its diagnostic tools. So the information that we provide you with using this microbiological test will helpful for you to decide on the targeted therapy. General statement on conventional microbiology. So they are very, very slow. So therefore, you have to keep the limitation of conventional microbiology laboratory that the tests that we provide with conventional methodology is very slow. So therefore, the empiric therapy is used to cover that delay. So, but you can't forget the conventional microbiology because it provides you some inputs to achieve phenotypic susceptibility testing. So this is the gold standard of antimicrobial susceptibility that needs to achieve antimicrobial therapy in a rational way. So conventional microbiology helps to confirm the viability of organisms. Now, when you consider the rapid molecular test, so you can't detect whether the organism is liable or dead with the test. But with conventional microbiology test, which is culture-based test, you will be able to confirm whether the organism that you are tackling is viable or not. And it also helpful to detect unexpected pathogens. So it provides a physical isolate for that you can work on. You can work on the resistant mechanisms and all. And at the same time, conventional microbiology, you can differentiate infection versus contamination, which is very important in antibiotic stewardship program. Otherwise, if you totally based on modern antigen detection or molecular detection methods, you won't be able to differentiate infection from contamination. So sometimes you might get a wrong report and you try to treat the contamination than infective agent. But when it comes to life-threatening conditions like septic and septic shock, so you can use rapid diagnostic methods. The use of advanced diagnostic technologies to detect, identify, and characterize microorganisms can be achieved with very short time, in minutes to hours. So that is an advantage of modern molecular test. So what are these rapid identification and rapid antimicrobial susceptibility tests? So generally, the conventional diagnostics, as I have mentioned earlier, will take some time, 48 to 72 hours. Rapid platforms can deliver identification of the etiological agent, and we can work out the antimicrobial susceptibility results within hours. So that is very advantageous when you are dealing a patient with sepsis and septic shock. So these rapid methods, rapid identification and rapid antimicrobial susceptibility test will facilitate timely targeted therapy, which is the aim of my talk. And it improves patient outcome, and it also helpful in antimicrobial stewardship programs. So now let's compare the turnaround times of traditional cultures and rapid diagnostic technologies which you can use in targeted therapy. So this diagram shows you, and it compares the culture and other test methodologies and the rough time taken for each of the test methodologies. Here you can see the traditional microbiology, which is culture-based technology. It will take around 60 to 72 hours to get the results. So initially 24 to 36 hours for culture, another 12 to 16 hours for biochemical identification, and another overnight incubation for achieve sensitivity. But when you compare it with the modern methods like biofire, mass spectrometry, peptide nucleic acid fish, so they will give the results well ahead, 24 to 48 hours ahead, so that in conditions like sepsis and septic shock, so you will be able to get the results early, so that targeting and focusing with narrow spectrum antibiotic will be faster, so that it will help in antimicrobial stewardship programs. So there are certain commercial platforms like Septifast, Iridica. So they will give the results within hours, and it will be helpful in sepsis and septic shock. So the rapidity in diagnosis has improved sepsis-related outcome. So worldwide, we know sepsis yearly causes 11 million deaths. And one way of countering sepsis is early identification of the pathogen so that you can target the therapy so that the outcome will be better. So this rapid identification system, although they are costly, so they will be helpful in achieving that. So we will now compare mortality outcomes with molecular rapid diagnostic test versus conventional testing in bloodstream infections. So you can see from this analysis, so rapid diagnostic test, especially in bacteremic cases, it will provide better outcome than the conventional tests. Overall, molecular rapid test significantly reduce the mortality, and modern molecular rapid diagnostic test, when you are associate it with antimicrobial stewardship programs, so it will reduce the mortality. But even if you use modern diagnostic test without incorporating it to antibiotic stewardship programs, so there is no significant reduction in mortality. So therefore, whatever you do with modern microbiological test, it has to be incorporated into antibiotic stewardship programs for the better outcome. It is not just infusion of new technology, but you have to use the new technology with objective of achieving antibiotic stewardship with all team members. So how are we going to transit from empiric to targeted therapy with the definitive microbiological inputs? First thing, pathogen identification. So with microbiological test, so you can transit from empiric to targeted therapy because we provide you information on what pathogen causes the illness. The second one, so we can provide you antimicrobial susceptibility testing so that you know that what drug to select. And then we can provide you what is known as minimum inhibitory concentration. So the minimum inhibitory concentration is the value that lab can provide, the best value, so that you can decide on what antibiotic, what dose, and what way that you are going to treat the patient. And also, we can help you by identifying specific resistant mechanisms, especially for modern, these new resistant gram-negative organisms. The treatment will depend on their antimicrobial resistant profiles. Although rapid diagnostic provides an early diagnosis, we cannot entirely replace conventional microbiology. Because, why? Because we have to live. So therefore, you can't replace conventional microbiology because it helps microbiologists to earn and live. So therefore, you can't replace it. So what are we going to achieve with the novel therapeutic approach? For critically ill patient, when the patient comes, you can't delay the treatment. You can start empiric therapy. So, and at the same time can take appropriate specimens for rapid diagnostics. With the rapid diagnostics, so you can identify the etiological agent within very short time and treat with the appropriate antibiotic. And then once the microbiological tests are available, so you can target the treatment with the inputs of the laboratory. Rapid diagnostic provide information for confident de-escalation. So you can start high, and at the same time, it will help you to de-escalate with the narrower spectrum antibiotic. For stable patients, so if you are managing a stable patient, the conventional microbiology is the gold standard. So you can wait, you can collect the sample, wait till the report and antimicrobial susceptibility, and can treat the patient. So rapid microbiological test will provide you the information needed to bridge the transient time period you convert from empiric to targeted therapy. Rapid diagnostic provide microbiological certainty needed to move beyond spectrum of antimicrobial empiric antibiotic. This certainty empowers clinicians to confidently de-escalate the treatment. The result is ensure that right patient gets right antibiotic at right time, minimizing toxicity and minimizing collateral damage. So what is the dual role of laboratory when it comes to optimizing patient care? By embracing the pathway that I have forwarded earlier, we can achieve two critical goals. For patient, we can optimize care, and for the public, so we can preserve antibiotic for the future. The most advanced diagnostic provide the data on effective patient care, and it requires collaborative wisdom from all sectors or all stakeholders in managing patients. And if you have any problem, so you can just take your mobile phone or telephone call and you can get some information regarding diagnostics or necessary antibiotics that you require with the microbiology team. Because the help is just a phone call away. Thank you very much.
Thank you very much, Dr. Kothalavala, for a very insightful presentation. So, yes, we would like to have you on stage. So the questions will be at the end of the symposium. So now I would like to invite Professor Andrew Seaton, consultant in infectious diseases at NHS Great Glasgow and Clyde, UK, Honorary Professor of University of Glasgow. So he will be talking to us on prescribe with purpose, the physician's role in antimicrobial stewardship. Over to you, Professor Seaton.
Thank you very much for the introduction, and thank you again to the college for the very kind invitation to speak here today. Those are my disclosures. I just wanted to start off by saying, you know, as internal medicine specialists here, you all know that antibiotics don't just treat infections, but in fact, they're the cornerstone of modern medicine. They do all these things. They make all these things possible that would not be possible without antibiotics. And in fact, in some sense, antibiotics are the foundation of, really the foundation of modern medicine. And it was this chap here, Alexander Fleming, a Scotsman working in London in St. Mary's Hospital, that made the fortuitous discovery that the mold, Penicillium, produced this antibiotic, which he named penicillin. And that really was the step, really, that has transformed modern medicine. But Fleming, in his Nobel laureate lecture, recognized that resistance was already emerging by the time that penicillin was put into clinical use. And this graph really just shows you the timeline between the introduction of any new antibiotic and the development of antimicrobial resistance. So what you can see is as we introduce every new drug, including some of the very new ones that you've seen in some of the pharmaceutical industry stalls through to the other room, every time you introduce one, resistance will develop. And antimicrobial resistance correlates closely with antibiotic use. And these data from Europe showing that those countries with the highest amounts of antibiotic use are associated with the most resistance. And antimicrobial resistance is important, as you all know, as really all infectious disease physicians effectively managing many patients with infectious diseases here in Sri Lanka, that the risk of dying with a resistant infection is almost double what it is treating an infection that is sensitive to the antibiotics. And obviously, antimicrobial resistance is an everyday living issue for you working in healthcare in Sri Lanka, but the data suggests that things are really only going to get worse unless we do something about it. And it's estimated that by 2050, we will see 10 million people a year dying as a consequence of antimicrobial resistance. So we have to act, and we have to act now. And the main thing we can do as clinicians here is through antimicrobial resistance. And yes, these are just some data that I pulled from your AMR report. So I work in Scotland where MRSA used to be over 40% of our Staph aureus infections. It's now less than 5%. We used to have a lot of third generation cephalosporin resistance, and now we have significantly less. And the secret is not using the drugs that drive the resistance. So the bigger picture, and we had an excellent presentation earlier, just highlighting what a big issue diabetes is for this part of the world. We know that diabetes is an epidemic, and these lifestyle factors that drive disease, whether it's ischemic heart disease, diabetes, smoking, and COPD, these are the things that drive infections, which drives antibiotic use, which drives antimicrobial resistance. So we need to take a bigger view of controlling antimicrobial resistance and going back to the fundamental causes, which is ill health within our populations. So antimicrobial stewardship is the bit that deals with the end result, stopping people using antibiotics inappropriately, but works in conjunction with vaccination. And I heard today earlier on, you don't have a full meningococcal vaccination program. I'm not sure if that's 100% true, but meningococcal disease is obviously entirely preventable with, as is pneumococcal disease, invasive pneumococcal disease, with vaccination programs. So these are really key things, along with infection control and stewardship, to curb antimicrobial use and resistance. And water, sanitation, and hygiene, and climate change, conflict, migration, all these things all kind of compound the problem of antimicrobial resistance. And that's without thinking about what goes on in animal husbandry. And these are projections showing that currently about 75% of all antimicrobials are used in animals. So we're actually in humans only using a little bit of it, a quarter of the sort of volume of antibiotics globally. But antimicrobial use in livestock is increasing, and it's increasing quite dramatically. And that big column there just shows you that it's a particular issue in Asia and the Pacific region. And we have to take a One Health view, as you've done in Sri Lanka in your AMR action plan, towards curbing antimicrobial resistance. But us, as physicians here today, we need to use our antimicrobials responsibly. And I thought twice about putting these slides in about the economic impact of AMR, because it's already here. It's already have a devastating effect, I would say, on healthcare and health costs. But this is important. The economic effect is important because it makes the rest of the world wake up to what antimicrobial resistance is going to do to global economies. So it's estimated if, at the worst scenarios, AMR is going to cost healthcare an increased cost of about $325 billion a year. And that's going to lead to a shrinkage of the global economy by $1.7 trillion. Now, that means nothing if you've got a multi-drug resistant infection here and now in Sri Lanka, but it does serve as a wake-up call for the rest of the world to do something about it, because it is the richer countries that really need to sort of push things on. And last year in the United Nations, there was a political declaration in September that all the nations of the world were going to pull together to make antimicrobial resistance a thing of the past, and really recognizing on a global level that resistance is one of the most urgent global health threats that we have. So the good news is we can do stuff about it, and if we implement good measures, develop new drugs, put antimicrobial stewardship into place, and use our antimicrobials more responsibly, we can turn the juggernaut round. And there's a relatively small amount of investment required in order to make this change happen. So the benefits are shown in your graph there on the right-hand side, and the graph on the left-hand side shows you the relative costs. So it's a lot of money, but if you put a little bit of money in, you get a lot back for it. So we need to think about this on a global economic scale. And here's the national strategic plan for combating AMR in Sri Lanka. And I'm just pleased to see that obviously this is a One Health plan, and antimicrobial stewardship and optimizing antimicrobial use in your country is really central to this document. Now, as physicians, you all know that unnecessary antibiotic use is not just associated with antimicrobial resistance, but it's 1 in 5 patients that come into our hospitals that get an antimicrobial will get some sort of adverse event as a consequence of the antibiotic. So this is another good reason to use them more responsibly. And you'll know that leaving a cannula in too long or cannula that's unnecessary is associated with device infections. And this is one of the major causes of Staph aureus bacteremia, at least where I work. And it draws in unnecessary nursing time and healthcare costs, delays discharge. So using less IV antibiotics wherever possible, particularly with targeted therapy where we can switch to oral therapy, is a good thing. And we've already mentioned in both our talks already antimicrobial stewardship, but really just to spell out, antimicrobial stewardship is an organizational approach to the safe and effective use of antimicrobials in order to optimize outcome and minimize harm, and critically, to preserve future therapies. It's about taking care of this very precious resource. And this is possibly the first example of antimicrobial stewardship in action before they knew it was antimicrobial stewardship. And this is a little sort of Second World War hospital just to the north of where I work in Glasgow. And this is a microbiologist called Douglas Slay. And Douglas Slay, with his neurosurgical colleagues, noticed that the patients on the neurosurgical unit were getting lots of infections with this bug, Klebsiella aerogenes. And he thought, Douglas Slay and his neurosurgical colleagues thought, I wonder if this is being driven by our antibiotics. So essentially, they resorted to using colistin to treat their infected patients, and then they resorted to just going back to real basics. If you had an infection, you were treated with physiotherapy, debridement. If you had a subdural empyema following a neurosurgical procedure, they would open it up, clean out the infection, but they didn't give any more antibiotics. And what happened? What happened to this new emerging hospital-acquired infection? Amazingly, it went away. And so this is the first example of this idea that you turn off the tap, you turn off the antibiotics, you can get rid of these invasive infections or antimicrobial resistant organisms. This is the hospital today, and this serves as a warning that if you don't keep up your efforts, your initiatives to control antibiotics, then things will go badly wrong. So you can never say job done as far as antimicrobial stewardship is concerned. So this hospital is rather dilapidated. There's moss growing over the roof. The windows have fallen in. So if we fast forward 40 years, this is another hospital not far from Killern Hospital where that first observation was made, and they were seeing huge rates of Clostridium difficile happening. In fact, this is a tiny little hospital, about 100 beds, but they had nearly 150 cases of Clostridioides difficile over about an 18-month period. And 34 people died. And these weren't all just very elderly, frail patients. These were lots of different patients. And this caused a huge media outrage, and quite rightly it did. But what we found was that this hospital was an example of what was happening in all our hospitals. And this problem was being driven for us by third-generation cephalosporins, quinolones, and beta-lactam, beta-lactamase combinations like cormoxiclav. So what we did when we recognized this, and this was in 2008, we stopped using cephalosporins. So we banned them. And instead of using third-generation cephalosporins, we used aminoglycosides. Now, I don't know what your resistance rates are like, but we knew that we could use gentamicin to treat our gram-negatives. And for that critical empirical period that you've heard about, the first 48 hours, well, that drug is still safe to use, 48, 72 hours. We stopped using cephalosporins, we stopped using cormoxiclav, and we went back to basic antibiotics, like they did back in Killern Hospital. And this is what happened to Clostridioides difficile. So we didn't just do it in that hospital, we did it in all of the hospitals in my health board, which covers a population of 1.3 million population, and then we did it all over Scotland. And essentially, almost overnight, this infection, Clostridioides C. diff, disappeared. But the other interesting thing we saw was that people with gram-negative bacteremia were surviving more. So we saw a significant reduction in mortality due to gram-negative bacteremia because they were getting a better drug, a more effective drug, which was gentamicin, so better than third-generation cephalosporins. And then we saw a reduction in resistance to coamoxiclav in our gram-negatives, as well as the third-generation cephalosporins. And the rate of third-generation cephalosporins for us then was about 20%, and it went down to about 8%. And then around the rest of the UK, we found that around the UK also, these kind of antimicrobial stewardship initiatives were the things that were driving down C. diff. So it wasn't because infection control measures were doing it. It was the control of the antibiotics. The better use of antibiotics led to less C. diff. And also, it wasn't just us. We observed MRSA going down where I work within Scotland, but then we saw that across the UK. So we went from over 40% MRSA to less than 5% MRSA. So you can have some hope that you can turn things around. You don't just need to keep piling more antibiotics on. Sometimes you have to take a step back and think, what can we do to turn this around? This is Lord Kelvin, the inventor of measurement, and he said, if you cannot measure it, you cannot improve it. So we all know, whichever field of medicine that we work in, that if you don't have data, you can't understand what's going on. And if you can't understand what's going on, how on earth can you improve it? So information and data is critical. So understanding resistance rates, understanding what your microbiology laboratory can tell you about resistance patterns is critical. And then education, guidance, engagement, and quality improvement and behavior change are absolutely crucial. So having a well-functioning microbiology lab that can give you quick answers is really important as far as antimicrobial stewardship is concerned. But at the end of the day, we want to start less antibiotics for people that come in with dengue fever, for instance, start more and stop more antibiotics, so using shorter treatments. So I'm going to rattle through, in the last few minutes, antibiotic decision-making. So 10 things for physicians. Diagnostic stewardship. So we've heard about diagnostic stewardship already, the right test for the right patient, the right interpretation leading to the right treatment. And it's in 3 phases. There's pre-analytic, which is doing the right test for the right patient. There's the analysis, which our colleagues in the microbiology lab do, and then there's the post-analytic effect, which is what you do with the test result. But basically, you do a bad test, you get a bad result. So for instance, if you swab that diabetic ulcer, it's going to tell you that there are these bugs growing there. They mean nothing. They don't tell you what's going on in the bone. So don't send off urine samples for culture unless somebody has urinary symptoms. So just basic things. And we've heard about the importance of diagnostics, so I'm not going to go through that. But just to say point of care testing to diagnose viral infections, for instance, dengue, you shouldn't just do these to diagnose the infection, but as part of excluding other things and saying, this is dengue fever, so I don't need to give them antibiotics. And then I'm a bit up and down about CRPs and procalcitonins because I think they're useful to monitor an infection, but they're sometimes expensive. So I don't use procalcitonin. I don't use it at all. It's an expensive test. I don't think it adds anything for me, but it can be useful for monitoring infection and shortening courses of antibiotics. And I'm just going to go back just to say, and I hope this is true for laboratories here, but more blood in the blood culture bottles means the greater chance of picking up a bug. So in my own hospitals and in the UK, we recommend 2 sets of blood cultures with somebody with sepsis in order to maximize the opportunity of finding the bug. Treat the patient, not the result. I think we can just leave it at that. That's about interpretation of the results you get. So whenever you get a result, and I spoke at a session earlier on this morning, you always go back and see the patient, examine the patient. Does this result fit with the patient? Don't treat the result from the laboratory. Treat the result in the context of the clinical context. The third thing is recognize that many infections will get better without antibiotics, and this is a big multi-center study showing that in primary care, people that don't come into hospital, with cough and bronchitis or cough and spit, essentially people will get better just as quickly without an antibiotic, with a placebo, as they will with amoxicillin. And there are lots of situations like that. So lower urinary tract infections, I know you see lots of ESBL infections here, but a lot of the lower urinary tract infections are self-limiting. So even if you give an antibiotic, if you don't give an antibiotic, you give an anti-inflammatory drug, fluids, they'll get better a day early. That doesn't mean for pyelonephritis, obviously, or bloodstream infections. Don't forget local measures. Again, going back to the experience in Cologne Hospital, where they went back to doing basic things like cleaning wounds, debriding. Remember that getting rid of lots of infectious dead tissue is really important in speeding recovery and enabling you to reduce the duration of therapy. And we know that if you've got an intra-abdominal infection and you operate, you can significantly shorten the duration of therapy. And sometimes our surgeons where I work are very reluctant to operate, and so we end up having to give longer courses of treatment. So having good surgeons or foot specialists who can debride wounds can shorten your therapy. And critically important, follow your guidelines. These are just examples of some of our guidelines. And if you follow your guidelines, your patients will get better quicker. Mortality is improved, time in hospital, time to discharge is improved. Everything is better. And that includes switching from IV to oral. This is the WHO aware classification. So in the UK, we've set a target for 70% of our antibiotics to be in the first-line access antibiotics. I know that's going to be difficult for you here, but we're trying very hard to minimize the use of the watch antibiotics. And then the reserve antibiotics are really only used on the advice of a microbiologist or an infection specialist. Remember drug interactions. For instance, my favorite antibiotic is doxycycline, but if you combine doxycycline with a cation, calcium, iron, magnesium, even in some of these preparations, nutritional preparations, it will prevent the absorption of doxycycline. So you have to separate it by at least 2 hours, and you absolutely cannot prescribe doxycycline with iron, because iron recirculates, binds the doxycycline, absolutely stops it working. So remember the drug interactions. I'll not talk through all of those, but it's really important. I don't get a sense here of how much penicillin allergy you see. In the UK, 15% of patients identify themselves as having a penicillin allergy. This was a patient I saw in the coronary care unit in my hospital who presented with VT, had torsade following the prescription of citalopram with levofloxacin in a penicillin allergy. And in this particular patient, the penicillin allergy was an episode of jaundice 50 years ago, so it wasn't an allergy. So lots of people think they have an allergy, but it's not. So it's really important to make an understanding, because using non-penicillin antibiotics is much more dangerous. And this was due to QTc prolongation due to the drug interaction. So take a proper penicillin allergy history, and penicillin allergies, increased resistance, increased length of stay, poorer outcome, greater cost. And we've developed some resources that can support you in that. And don't forget, document and review, IV to oral switch as soon as you can, particularly if you have targeted therapy or in the improving patient that can eat and drink. And when you prescribe oral therapy, give a limited course and limited duration. And that's just really to show that oral therapy is as good as IV therapy for bone and joint infections if you use the right drug. So I've now shifted completely to treating all bone and joint infections with oral antibiotics. Endocarditis, you can treat with oral antibiotics after initial IV. Bacteremias, and shorter courses are better than longer courses. And I unfortunately don't have time to go into this. I discussed this morning. And the last thing, I know that we're all physicians in the room, but don't forget the value of our other colleagues, the nurses who do all the observations, who recognize when patients are getting better, who notice when patients are managing to eat and drink and can go on to oral therapy. So the nurses are critical for helping as stewardship, as well as our clinical pharmacists. And this is just data showing the support I get from my nurses in our outpatient treatment program for managing cellulitis. And I wanted to tell you about this. This is the society that I'm here representing today, BSAC. We have a program we're developing about leadership for non-infection specialists. So for everyone who's not an infection specialist, so we're developing this program, Leadership to Embed Antimicrobial Stewardship in Practice. If you want to know more about that, please join the society by scanning the QR code. And we also have an accreditation scheme, which might be of interest to you for promoting stewardship in your hospitals. And we've been engaging with people all over the world, and in this region, particularly in Gujarat. But yes, as you can see, we've got this program going all over the world. So if you're interested, please come and speak to me. And apologies for going over my time, but thank you very much for your attention.
Thank you, Professor Andrew. Our last speaker is Dr. Jitendra Burmacha, MD, MPH, MACP, Associate Professor of Clinical Medicine, Kearney School of Medicine, New York. Over to you, Jitendra.
Good afternoon, everyone. And it's a little bit challenging to follow Andrew and Dr. Mahan, but I'll try my best to comply with the request which I received a few months ago. Is there any way you can put the slides or? All right. So the next 15 or 20 or 25 minutes is Sepsis 2025, Evolving Insights and Emerging Interventions. And you will see where my history is very important for me. And we can learn so many things from history so that we are better prepared for the future. And this is my credentials where I work in New York. And this is our learning objectives. And I'll start with the definition, which is very, very important before we get into the emerging concepts. So I underlined few words. Please pay attention. That has been the theme of this conference. Whether you attended diabetes or PCOS or heart failure, it's a heterogeneity. So it's a heterogeneous syndrome of acute organ dysfunction caused by dysregulated, very, very important word, dysregulated host response to infection. And this particular definition came about 10 years ago, almost 10 years ago. And the future definition may change in a couple of years. So as I said, history is very important, although this slide may be a little bit busy for those who are sitting in the back. In 400 BC, Hippocrates came up with this notion of defining sepsis as to decay, or from the Greek word called to rot. Over the period, when I graduated from medical school in 1992, the first concept of SIRS came out. And during our medical school, we had no idea what was that. So we have come a long way. And in then 2003, they added some more variables to define sepsis. And last definition came out, as I said, about a decade ago, where they included, they changed the definition of sepsis, which I just elucidated. They included lactate levels and also some other variables. So the future, which is sepsis 4 definition, will be coming out soon. It will be more based on phenotypes or the heterogeneity, as I mentioned. So as Dr. Mahan mentioned, it's a global public health problem in the all around the world. Almost 50 million cases with approximately 11 million deaths worldwide annually. These last 3 data are from the US, and I'm sure they are similarly reflected in the other parts of the world. Almost 7.5% of all hospitalizations and nearly 10% of the total hospital days. 1 in 3 hospital deaths are related to sepsis, and it's one of the most expensive ICD-10 in the US for hospitalized patients, almost $52 per year. Regarding the sepsis definition over time, it has become a little bit easier if you compare from sepsis 2 or sepsis 3 definition. Again, there has to be a suspected or documented infection. And what generally in my hospital and other hospital around the area, we use QSOFA, and I'll go into details about what QSOFA is. Basically 3 parameters of systolic blood pressure less than equal to 100, altered mental status, and respiratory rate more than equal to 22 per minute. What is new in the last definition? There is no severe sepsis. So you have sepsis and then septic shock. So as I said, the 2016 definition was based on 1996, those variables called sequential organ failure, sepsis related, for assessment update. Only in I think last week of October, SOFA 2 came out. So it's almost like 30 years this SOFA has been changed. What they have included is the newer targeted therapies like ECMO and also variables which are not present in the initial part of the assessment. Again, I don't want to go into details about that, but again, it took almost 20, 30 years to change all these variables. These are some of the variables which are new. Most important are the brain functions or cognitive impairment, and the other ones is the targeted therapy, what we use generally. In terms of mortality, it is up to 50% if you have multi-organ dysfunctions. Generally, sepsis has around 10 or 12% mortality. But it's almost like 50% when you go from septic shock to multi-organ dysfunctions. Very quickly, what are the sources? Most commonly are pulmonary and abdomen and GU in that order. But after age 65, urinary tract infection is the #1 cause. So even if you're taking board exam, that should be your answer. Anyone who is elderly, above 65, the commonest source is the urine, not the pulmonary. And in terms of infections, gram-positive and negative bacteria are the commonest, and then followed by fungal or viral. In terms of risk factors, again, I'm not going to go into details, but most important is as the oncology diseases are rising across the globe, please pay attention on people who have cancer. They are becoming one of the most common risk factors apart from others, bacteremia, advanced age, ICU admissions, community-acquired pneumonia, and also previous admission in the ICU because of the skin and the gut what they call is the gut issues which can lead to the future septic infections. So in terms of early warning, none of these have 100% sensitive and specificity, but it does help in identifying or risk stratifying. Both news and muse are equally important, but I think news 2 came out in UK. It was originally from UK news, and news 2 came out I think about a year or so. What they have included in news 2 is the, again, cognitive impairment or delirium. And the difference between the news and muse is most important is the not only oxygen saturation, but if you are giving supplemental oxygen. So if you are looking for ICU admissions, I think these 2 parameters are very good. But in our hospital, we usually use QSOFA. Those are 3 straightforward parameters which does not require any invasive tests and all. But with the advent of electronic health record, and we have so many meta-analysis, again, any talk is not good if you're not talking about artificial intelligence tools. So there has been a good effort on looking at the AI tools to predict or risk stratify these individuals. So based on the EMR data, based on the clinical parameters, and based on the complex algorithms, whether they are large language models or small language models, they are coming up with the sepsis early prediction or diagnosis or a tailored treatment. I'm going to just highlight 1 or 2. The first one is from Johns Hopkins, Bayesian Health. This is the targeted real-time early warning system called TRUES. These are based on the EHR data. It just predicts for the risk, the risk stratification for patients with early sepsis. And based on the available data, 3% reduction in sepsis-related mortality. So that was a very good tool which came based on the large language models. The other ones are still in infancy, or I would say needs more research, whether it is SPOT or Sepsis Watch. We use Epic EHR. Their model is not that great. They are still fine-tuning it. So in near future, hopefully we'll have a better tool. Now, very quickly on the pathology, if you have any trigger or any insult from any pathogen, 4 things can happen. Either you have multi-organ failure, early death, or you can have a very early survival because your immune system is strong. But then those 2 are the late deaths based on the nosocomial infections, or you have a lifelong morbidity and so forth. So if you want to learn from today's discussion, just remember 2 things. One is the hyperinflammatory state when there is a pathogen, and then the immunosuppression by the host. So there is a disbalance, that's why it's called dysregulated clinical syndrome. So the targeted therapy either for early detection is based on the how the host reacts to an insult. And with a better understanding of our immunity, whether it is innate immunity or cellular or humoral immunity, there are more and more biomarkers, which I'm going to talk a little bit about them. So the future targeted therapies are based on those models. In case of immunosuppression or immune paralysis, these are based on how the insult happens from the insults or the pathogen. Because of heterogeneity, some of the cytokines or the biological markers, they impact more vascular structure than the other structure. That's why some of the patients have more DIC and increased thrombosis and decreased fibrinolysis. And these are some of the major organs which are impacted, or they are being clinically monitored at various services, whether in the ED or in the ICU levels. Again, a very complex pathobiology diagram, but 2 things we have to remember. One is the pathogen-associated molecular patterns, which is called PAMPs, and the other one is when they damage our endothelial cells, it's called DAMs. So both PAMs and DAMs, they trigger all the biomarkers or the pathology, and our future treatment or the current treatment are based on how these DAMs and the PAMs are triggering our host response or host immunosuppression. So why there are challenges in diagnosing sepsis in clinical practice? So systemic inflammation can be due to non-infectious causes. Routine diagnostic tests, they have very low sensitivity, and the transition from infection to sepsis is very difficult. Not all infection result to sepsis. There are only few which results into sepsis. And also sometimes comorbid conditions can mask our sepsis as well. The tool which we use, QSOFA, is not very, very specific for infection. It can be present in other conditions as well. So the next maybe few minutes, I'm going to talk after the physical exam. Yesterday, Dr. Ganake, I think he was mentioning about importance of physical exam. So this is very timely, and there are literature which suggests that if you do capillary refill test at the bedside, the outcome is much more better for the patient. So please do not forget physical exam. And also these semi-recumbent position for sepsis bundle to those, especially those who are on ventilators. I'll quickly go through some of the lab tests, although Andrew does not like procalcitonin, but every patient who comes to our health system or across the US do get procalcitonin or serum lactate levels or CRP, one of those other flavors, depending on how your care pathways are drawn. So blood serum lactate levels, they are both hemodynamic and metabolic marker, and now they are part of sepsis 3 definition. So you must have serum lactate levels in order to have ICD-10 diagnosis. The payers will not pay actually in US if you don't have those tests. It's an indirect marker for tissue hypoperfusion and cellular stress, and it's not a direct measure of tissue perfusion. It's very, very important. We think that it's tissue hypoxia and the blood lactate. That's not true. It can be used as a prognostic marker in sepsis if you have a very, very high levels and a poor clearance. And these individuals have a very increased short-term or 30-day mortality. But as you all know, lactic acidosis can happen outside of sepsis as well. So be very careful if you're only looking at that test. C-reactive protein, this is an acute phase reactant. It is highly sensitive, but it is not very specific. And these can be increased in any of these metabolic or inflammatory syndromes. So be careful when you're ordering C-reactive protein. There is a new marker called estimated CRP velocity. This is a novel marker to differentiate between bacterial and viral infections. And if your eCRP velocity is more than 4 milligram per liter per hour, that is a very strong indication for bacterial infection. So stay tuned, more to come on eCRP velocity test. Procalcitonin, Andrew, you can close your ears for 30 seconds. This is a pro-hormone everyone knows about from the calcitonin. If you have a sepsis which has a urinary or meninges onset, you can check those levels in those specimen as well if you have done CSF fluid or the urine. Some of the clinical guidelines do recommend discontinuing antibiotics when procalcitonin level falls below 80% from the peak levels. So again, if you have a level during the initial admission and then after a few days, if you see the level have come down below 80%, either you can reduce or you can, most of the time they are reducing antibiotics. Nobody stops antibiotics in usual practice. Again, it is very, very important or useful in ruling out diagnosis of sepsis, not ruling in. So. And based on our host response, these are the newer markers which are in the pipeline, not very useful currently in the clinical, only in some hospitals are being used. They are tumor necrosis factor, IL-10 and IL-6. They come into the bloodstream much faster than, much earlier and faster than procalcitonin and other biomarkers. So, as Dr. Mahan mentioned, early detection is very, very important. Apart from the organism, there are some tests which are available and FDA approved and which we are using for early detection. This falls into 3 categories. First one is based on cells, second one is based on gene expression, and third one is based on protein. And some of them can be used as a point of care testing. I will breeze through them so that you are at least aware and you can really prevent ICU admissions and giving antibiotics so that we can reduce the use of empiric antibiotics. The first one is the monocyte distribution width. It is very, everybody gets CBC. So if you look at the monocytes, they are the very important effector cells, unsung heroes. And if you look at the monocyte distribution width, this is a very, very important marker for early detection for sepsis. The second one is the IntelliSep index, which leverages the biochemical properties of WBC. It comes into the band. It is highly sensitive, but not very specific. So if you have a band of 1, the chances are the patient do not have or will not have a sepsis. And if you can, this is just a diagram to show how pliable the cell membranes are using those tests. And if you have band number 3, then the chances are the high probability of sepsis. These individuals should be admitted to ICU. The third test is protein-based, differentiating between the viral and the bacterial. These are immunoassay based on the host response. On the interferon 10 and the CRP levels. Again, based on the scoring, you can essentially rule out or rule in, and you can either give your antibiotics or just observe them till the organisms are based. So the third one is the looking at the RNA transcripts, PLA2G7 and PLA-CC8. By the way, all these tests are FDA approved and are being used mostly either in the pre-hospital care or at the emergency room to prevent giving antibiotics or the decreasing the length of stay. Last but not the least is looking at the not only the differentiating between the bacteria and the viral infection, also the non-infectious illness also. And it is very important for this particular test is very important if someone, you can easily predict that whether these patients will go into septic shock so that you can prevent giving vasopressors and so forth. These are based on the mRNAs test, and they are coming to one of the EDs or hospitals near you. Again, this is a summary slides of based on what I discussed about the cell-based or protein-based or the molecular-based of the early testing. In terms of sepsis management, quickly I'll not going to talk about details about this sepsis management, but what are the emerging concepts and what are the important treatment plan which you can think of. But before go into the one size does not fit all, with that concept, now we are looking at the phenotypes. Some patients will have more of lung infections, some patients will have more of DICs. So there are 4 phenotypes, alpha, beta, gamma, and delta. So if you see based on the 4 different phenotypes, you can gear towards these therapies. So this concept is emerging, and hopefully in the near future, we will be targeting those therapies based on the individual's phenotype. In terms of pillars, there are 4 pillars for sepsis management. First and foremost, Dr. Mahan and Andrew already mentioned, infection, take care of the infection and antimicrobial agents whenever or wherever they are appropriate. Second one is the source control. So if there is a catheter or any costumes, please remove them before you are treating those antibiotics, because any indwelling catheters or blood vessel catheters are a vector for the infection. Number 3 is the adequate perfusion. 30 ml is the ideal dose for series boluses. You must start with ringer lactate or plasma light and then followed by normal saline. This is one area where you should not start with normal saline, start with ringer lactate based on the studies. And if there is a severe or persistent hypotension, please, the number 1 drug of choice is the norepinephrine, followed by epinephrine or dobutamine if they have decreased cardiac output. In terms of corticosteroids, these are under the adjunctive therapies, and based on the last year's Society for Critical Care Medicine, there is a value for corticosteroids in terms of hydrocortisone in septic shock and also those who have complicated community-acquired pneumonia. In terms of daily protocol using procalcitonin, these are evidence-based studies. CRP is not useful in decreasing the antibiotics, whereas prolactin has shown some usefulness if you follow them periodically. In terms of capillary refill time, again, a very good study that you must do capillary refill time every single day, so you have a better outcome. These are some of the emerging biomarkers. Again, very busy slides. I will not go into details, but again, some of the tests we are currently doing it. They are just modifying those tests so that we can do early detections. And the difference between the traditional and the newer markers they are more specific and more sensitive, and they are very rapid. If you are using them as a point of care testing, the results can be in minutes rather than hours. These are some of the investigational therapies based on how the host is responding. So the most important ones are the first and second, which is the immune checkpoint inhibitors, and the second one is cytokine-based immunomodulations. There are other monoclonal antibodies, but those are mostly for the research purpose. And again, these are investigational depending on which target. Instead of giving like a empiric, we should be giving target as we learned from Dr. Mahan earlier today. Pre-sepsis, this is a newer concept. Please remember, especially with the wearables. I mean, I'm not going to advertise Apple Watches, but with the new Apple Series 11, now you can have hypertension. Hopefully in 12 or 13, you will have temperature based on this. So wearables are going to be very, very important, especially those who are taking chemotherapies and immunosuppressants. This is a relatively a newer concept, and more to come on. There's a very good study which came out in Long Island from New York, where they gave wearables to those individuals. It significantly decreased their length of stay in the hospital and also decreased their emergency visits. So more to come on the wearables. Again, not going into details in the interest of time, precision diagnostics are coming, and they are coming very fast. Based on the phenotypes, more and more personalized therapies. And now that we have so much good data, and along with electronic health records, we can usually create a very complex algorithm so that we can predict much earlier. In summary, again, it's a very heterogeneous syndrome with very dysregulated immune response. And the emerging concepts are focusing on more and more on the precision medicine. And I have one question for the audience. Which is the World Sepsis Day? Anyone? Please do not use ChatGPT or Google now. Anyway, so it's September 13 is the World Sepsis Day. With that, I think that concludes my session, and I apologize. I was about a minute or two, a little bit longer.
Thank you, Dr. Burmicha. Please join us. The floor is open for any questions. So may I ask one question from Dr. Kotalawala? So in a country like ours, like in a low-middle income country, we do talk about antimicrobial stewardship, preserving our antibiotics. But how do we navigate these challenges of unavailable drugs, especially when narrow-spectrum antibiotics are not available? So how do we actually tackle this situation at the moment?
So in our country, we have two different issues. One is non-availability of antibiotic in community level, and the non-availability of antibiotics to tackle the resistant organisms which we encounter in hospital modes. So those are the two things that we are having at the moment. At the moment, the main problem that we, in the National Hospital, we face is non-availability of antibiotics to tackle the resistant organisms that we encounter. So we encounter large, being a developing country, we see a lot of carbapenem resistance among our enterobacteriales. We see a lot of, nearly 90% of our Acinetobacter are carbapenem resistant. 50% of Klebsiella carbapenem resistant, and we don't have access to antibiotics which are effective against those things. Only thing is colistin availability. So the colistin is also, we all know that colistin is not a good drug for lung, blood, and other than urinary tract. So even the colistin, sometimes we are using lower doses, not the recommended doses as 9 million with a loading dose and 3 million unit 8 hourly. So that will cost huge amount. So that we don't have access, and sometimes even if we have access to antibiotics, we use lower doses, which is profoundly pushing our isolates into issues at the community level. And actually it is not non-availability of resources. It is, the issue is with not money. The getting it down. The process is very tedious, especially in the government sector.
From there, actually, I would like to ask Professor Seaton, because you had a very good control program where you were able to kind of combat C. diff infections by strict, kind of policy decisions. So how do we now, in a country like ours again, where the cost is a major factor, so how do we incorporate these novel, like, investigations in a cost-effective manner, as well as have these policymakers kind of get them involved into making proper policy decisions on getting a best benefit out of what is available?
Thank you. 18 seconds on the clock. I think it's difficult, and I think you have to understand the susceptibility to all the common organisms and look at which common organisms can be treated with narrow spectrum or access antimicrobials. You have to promote the use. You have to be able to recognize which patients don't need antibiotics and start dealing with them and promoting that in a public health way. Stop prescribing antibiotics for people with coughs, colds, viral infections, just fevers, but be able to provide access to those people that most need them. But I think it's about for the sick patients in hospital, as we heard in the first presentation, they have to get the right drug at the right time. But what other drugs can we use? Can we use aminoglycosides up front? Because if you have susceptibility to aminoglycosides because you don't use them much, that might be an answer, because that was our answer. But if you've got high rates of resistance to amikacin or gentamicin, then that might not be an option for you. So targeted diagnostics earlier, switching of therapy based on the laboratory, but it's a big, complicated problem. And you have got an action plan, which I've read, which is very impressive. And start with the microbiology, start with a public health way of thinking about this.
Thank you very much. So with the interest of time, I would like to thank all of three of our speakers for a very informative and interactive session as well. And I would like to invite Dr. Nguyen to hand over the certificate, the token of appreciation.